Welcome back to our explainer on posterior circulation stroke. Today, we're diving into what I think is a clinician's real superpower, pattern recognition.
So here's the game plan. We're going to take a systematic tour right up the brainstem. We'll map each major artery to the exact clinical picture it creates when there's a problem. By the time we're done, you'll have this map pretty much burned into your brain.
This right here, this is the whole point. Imagine being able to see a collection of symptoms and boom, you know exactly which artery is in trouble. This is about being fast, being right, and saving brain when it really counts, especially when a massive stroke is hiding behind something as common as, a bit of dizziness.
Okay, let's get into it. First stop on our tour, we're starting right at the bottom with the posterior inferior cerebellar artery, or as we all know it, the PICA.
So take a look at this. The PICA feeds this really crucial piece of real estate, the side of the medulla and the bottom of the cerebellum. Now this anatomy, this is everything. Because when you block the PICA, you get one of the most classic textbook syndromes in all of neurology.
And here it is, the famous Wallenberg syndrome. Now I know it looks like a whole laundry list of symptoms, right? But what's so incredible is that every single one of these signs maps perfectly to a tiny structure in the lateral medulla. You get the vertigo from the vestibular nuclei, the ataxia from cerebellar tracts, and that classic crossed sensory finding we'll talk about in a second. It's like this beautifully laid out but very dangerous clinical puzzle. And here is the payoff on the MRI. See that glowing white spot? That's it. That's the infarct, right there in the lateral medulla. This is the image that proves what you already figured out just by examining the patient at the bedside. It's when it all just clicks.
So if you remember one thing about PICA, make it this, that crossed sensory pattern, feeling weird on one side of the face and the opposite side of the body. That's not just a clue. It's a giant flashing neon sign pointing right at the lateral medulla. It's your diagnostic anchor for a PICA stroke.
All right, let's head a little further up the highway. Next up is the anterior inferior cerebellar artery, the AICA. Now this is where things get really tricky. This is a huge diagnostic pitfall. An AICA stroke can look almost exactly like a simple inner ear issue. I mean, the patient has vertigo, nausea, vomiting in both cases. But there is one massive clue, one thing that separates a benign problem from a disaster, and you absolutely cannot afford to miss it. This is the rule, and it's a non-negotiable one. If a patient comes in with acute vertigo and sudden hearing loss on the same side, that is an AICA stroke until you have an MRI in your hand that proves it isn't. It's not labyrinthitis, it's not vestibular neuritis, it's a brainstem stroke, and it's a code red. And why does this happen? Well, it all goes back to the plumbing. The AICA sends off a tiny branch that supplies the inner ear. So when the AICA gets blocked, you take out the ear. Boom, vertigo and hearing loss. But the main artery also feeds the side of the pons, so you might get other stuff too, like a facial droop or some limb ataxia. It's a real double whammy. Okay, now we're moving up to the big one, the main highway of the posterior circulation, the basilar artery. And a blockage here, well, it's not just serious, it is often catastrophic. Occlusion of the basilar artery can cause a massive stroke right in the pons, leading to one of the most terrifying conditions in all of medicine, locked-in syndrome. The patient is quadriplegic, unable to speak, but their mind is completely intact. They're awake, they're aware, they can hear everything, but they are literally trapped inside their own body. So here's your job. When you walk into a room and find a patient who seems suddenly comatose, you have to fight that instinct to just assume they're unconscious. You have to look for that one flicker of life. Get in close and ask them, can you look up for me? Can you blink? If you see that movement, you've just diagnosed a basilar artery occlusion, and you may have just given them a shot at a life-saving procedure. And that's not the only trap with the basilar artery. If the clot lodges at the very top, what we call top-of-basilar, you get another great mimic. These patients can seem really bizarre. Confused, lethargic, maybe even having vivid hallucinations. It's so easy to go down the wrong diagnostic path. But the clue is almost always in the eyes. Check their vertical gaze. If they can't look up and down properly, you are not dealing with psychosis. You're dealing with a brainstem stroke. Finally, let's talk about large strokes that hit the cerebellum itself. These present a completely different kind of time-critical emergency. It's not just about the ischemic tissue anymore. It becomes a flat-out race against swelling. The most important sign here is a profound inability to maintain core stability. And listen, this isn't just feeling a bit wobbly. This is a patient who, if you try to sit them up on the edge of the bed, will simply fall over like a rag doll. This profound truncal ataxia is a massive, massive red flag.
So why is this so urgent? What's the big emergency? The problem isn't just the dead brain tissue. The immediate, life-threatening danger is something else entirely.
The danger is swelling. You see, the cerebellum sits in a tight, bony box at the back of the skull. When it swells up from a stroke, it has nowhere to go. It quickly starts to compress the fourth ventricle, which blocks the flow of CSF, and then it literally starts to crush the brainstem itself. This is a ticking time bomb, and it is a neurosurgical emergency that can be fatal within hours. Okay, we've covered a lot of dangerous territory. Now, let's consolidate all of this into a simple, practical map that you can actually use at the bedside. Here is your cheat sheet. PICA gives you that classic Wallenberg syndrome with its unmistakable crossed sensory signs. AICA is the great mimic, but the key is vertigo plus sudden deafness. The basilar artery, well, that causes the catastrophic locked-in or the top-of-the-basilar syndromes. And a large cerebellar stroke is all about that profound truncal ataxia. If you only take 3 things away from this, make it these. Burn these patterns into your clinical memory. They are high-yield, high-stakes associations that will allow you to spot these dangerous strokes and act decisively. Recognizing the pattern is the critical first step. In the final explainer of this series, we're going to focus on what to do next, how to translate these patterns into time-critical decisions about imaging and management. To continue building your expertise, make sure you subscribe to the Australian Dizziness Clinics channel. And for our full library of resources just for clinicians, head on over to our website.